Welcome. Today we're focusing on something really common in urgent care and emergency settings, pediatric bone injuries, specifically those incomplete fractures.
That's right. Getting the diagnosis right is key because the management can be quite different.
Exactly. So our goal here is to quickly run through the essentials for three main types: the buckle, the greenstick, and the bowing fracture.
And it all comes down to the unique properties of children's bones. They're just much more flexible, more elastic than adult bones. So when they experience stress, they don't always snap cleanly. They often bend or, crack partially. That's where these incomplete fractures come in.
Makes sense. Let's start with maybe the most frequent one. We see the buckle fracture, sometimes called Torus fracture, right? What's the defining feature here?
The torus or buckle, the defining thing is compression. Think axial load force pushing down the length of the bone.
Okay, an axial load. And how does the bone react to that push?
Well, one side of the cortex, the outer layer, it sort of crumples or buckles outwards. Imagine squashing a cardboard tube just a bit on one side.
Oh, okay, a bulge.
Exactly, a bulge or a bump. But, and this is important, the cortex on the opposite side stays perfectly intact. No break there.
So that makes it stable, inherently stable then.
Very stable.
And what's the classic story? How does this usually happen?
Almost always a foosh, a fall on an outstretched hand. That impact travels right up the arm.
Right.
And you'll most commonly find these near the wrist in distal radius or ulna. That wider part of the bone near the growth plate seems susceptible.
Okay, so location is key. But on the X-ray, if there isn't a clean break line across the bone, what are we actually looking for to confirm it?
You're looking specifically for that cortical bulge. It might be subtle. Sometimes it looks like a little ripple or bump on the edge of the bone.
No actual fracture line then?
Usually not, no. It's that circumferential bump that gives it away.
Got it. And given that stability, what's the usual plan? Does it need much intervention?
Treatment is generally pretty straightforward. A removable splint, sometimes a short arm cast, mainly for comfort and protection.
And reduction. Setting the bone.
Almost never needed. The alignment isn't significantly disrupted.
How long are we talking for recovery?
It's quick, usually just 3 to 4 weeks in the splint or cast. The prognosis is excellent, healing is fast, complications are really rare.
Okay, that's clear. Buckle fracture. Compression, bulge, stable, simple splinting. Now, what if the force isn't compression, but more of a bending action? Let's move to the greenstick fracture.
Right, totally different mechanism, different look.
How does the greenstick pattern differ from that buckle bulge?
With a green stick, you get failure on the tension side. So the side of the bone that's stretched, the convex side, it cracks open.
Okay, it cracks.
But, and this is the key green stick feature, the other side, the compressed or concave side, it stays intact. It bends, but doesn't break through.
Hence the name, like bending a fresh green twig.
Exactly that. The outer fibers splinter, but the inner core holds.
And where do these tend to happen? Still near the joints?
Less often near the joints, actually. More common in the shaft, the diaphysis of the long bones. Think radius, ulna, tibia, fibula, the straight parts.
So when looking at the X-ray for a greenstick, what are the critical details beyond just seeing a crack on one side?
You'll see that sharp cortical break, but only on one cortex. Very often there's associated angulation. The bone is visibly bent at the fracture site.
Right, because one side broke, allowing it to bend.
Precisely. And another subtle thing to look for the periosteum, that fibrous sleeve around the bone, it usually stays intact on the compressed side. It acts like a hinge, preventing complete displacement.
Okay, so that intact periosteum provides some stability, but the angulation is the main issue, unlike the buckle. Does this mean treatment is usually more involved?
Yes, generally it is. It really depends on how much angulation there is.
Okay.
If it's just mild angulation, maybe less than, say, 15 degrees, casting alone might be enough. The bone's remodeling potential can handle small deformities.
But if it's bent more significantly?
Then close reduction is typically needed. You have to straighten the bone, correct that angulation before putting the cast on.
Yes.
Sometimes this needs sedation or even brief anesthesia.
And assuming we get good alignment initially, what's the outlook for greenstick fractures?
Generally very good. Especially in younger children, that remodeling capacity is phenomenal. They can smooth out minor imperfections over time. But getting that initial alignment right, particularly correcting significant angulation, is really important for the best outcome.
Right. Okay, so buckle is compression. Greenstick is tension failure on one side, often with angulation. Now for the trickiest one, maybe, the bowing fracture, also called plastic deformation. No visible break line here, often.
Yeah, these can be subtle. It's literally the bone bending and staying bent.
How does that happen? How does a bone bend permanently without snapping or showing a clear crack?
It's usually due to a force that's applied over a slightly longer duration, or perhaps repetitively. It's not usually an instantaneous sharp impact like the others.
Okay, a sustained force.
Yes. That prolonged stress causes microscopic failures throughout the bone structure, tiny little microfractures. These allow the bone to deform plastically, meaning it changes shape and doesn't spring back. It takes on a permanent curve.
Like bending a pipe cleaner or something?
Sort of, yes. It yields rather than snaps. No single visible fracture line on the cortex.
Okay, if there's no fracture line, where do we typically see this kind of bowing injury?
Most commonly in the ulna or the fibula. Often it happens when there is a fracture in the paired bone, like a fractured radius might allow the ulna to stay under the force, or a fractured tibia allows the fibula to bow.
I see. The paired bone takes the break, the other one bends.
Exactly. The force gets transmitted, and the more flexible bone deforms.
So on the X-ray, besides just seeing a curved bone, are there other clues?
The primary finding is the visible bowing or curvature compared to the normal side or expected anatomy. Sometimes, especially if it's been there a while, you might start to see some thickening of the cortex on the concave side, the inside of the curve.
The bone trying to reinforce itself.
That's the idea, yes. Compensatory thickening.
Now for treatment, I understand there are some pretty specific guidelines for bowing fractures based on age and the degree of the bend.
Yes, this is where the numbers become important. The threshold often cited is related to age and the angle of the bow.
Okay, what are those thresholds?
Generally, for children under 4 years old, if the bowing is 20 degrees or less, immobilization might be sufficient.
20 degrees, okay.
Below that angle, in that younger age group, there's often enough remodeling potential for the bone to gradually straighten itself out over time.
But what if the bowing is more severe, over 20 degrees, or in an older child, or causing problems?
Right. If the angle is greater than that 20-degree mark, or if the bowing is causing a functional deficit like loss of forearm rotation, if the ulna is significantly bowed, then intervention is usually required.
And what does intervention look like for a bone that's plastically bent? It sounds tough to straighten.
It is. It requires a closed reduction, but it often needs significant force under general anesthesia. You essentially have to carefully unbend the bone, reversing that plastic deformation to get it straight before casting.
Wow, okay. Needs a proper orthopedic procedure then.
Often, yes. It's not something to be taken lightly.
But if you do intervene and get it straight,
the prognosis is usually favorable, especially if caught and corrected relatively early before the bone really solidifies in that bowed position.
Okay, let's quickly recap. We've got buccal fractures from compression, usually stable, greenstick fractures from bending, with a crack on the tension side, needing alignment check, and bowing fractures, the plastic deformation, which might need reduction based on that specific 20-degree angle and age.
Exactly. I think the main takeaway for management is really stability and the need for alignment. Buccal fractures, stable, minimal intervention, green stick, you've got to assess that angulation carefully. Reduction might be needed. Bowing. Check the angle, check the age, check function that guides whether you need to intervene more aggressively.
And underlying all of this is that amazing pediatric bone remodeling. It influences everything, doesn't it? Especially for something like a green stick, getting that alignment right initially gives that remodeling the best chance to ensure a full recovery long term.
Absolutely. It's a huge factor in pediatric orthopedics.
So a final thought for everyone listening. Next time you're looking at pediatric films, especially forearm or lower leg, and maybe things look generally okay because there's no obvious fracture line, take another look. Could there be a subtle plastic bowing, maybe just over that 20-degree threshold that you might otherwise miss? Something definitely worth keeping in mind.